today. It's like, yeah, it's just like the middle. It's like I missed the rapture. Okay, from on yesterday. Which of these tumors has what? So, Ewing's, does it have osteoid substance or small round blue cell? Small round blue cell. Does the rhabdomyosarcomas? Small round blue cell. What about osteosarcoma? Osteoid substance. Most common pediatric leukemia? Okay, up. Reed-Sternberg cells go with? Okay. What is the most common presentation of a teenager with a lymphoma?
The lymphadenopathy.
Lymphadenopathy where? Cervical, and the one that's kind of pathognomonic a little bit. You guys are all right here. What's this one?
Supraclavicular.
Supraclavicular. So that's one. If you don't catch that, and then they come to the ER, what's their emergent presentation like for lymphoma? Shortness of breath, respiratory distress. Correct. Yep. Which tumor in a toddler has an abdominal mass and hypertension? A Wilms tumor. What's the other name for a Wilms tumor? Nephroblastoma. Yep. What's your other one that's like that one? Yeah. What's the worst acronym ever? Wager. What does it stand for? Wilms tumor, which is a? Nephroblastoma. What's the A? Really, really close. Aniridia. Exactly, yes. Aniridia. G?
You lost us.
Urinary symptoms, yes! Yes, malformation. And range of developmental delays. Worst acronym ever. I'm telling you, it's the worst one. Okay, we did that one. Okay, we'll finish up endo, letting me live my dream. Thank you so much. Started at the end with metabolic disorders yesterday. When, as a reminder, when do you get that first newborn screen? Yeah, 24 hours. Yeah, so 24 hours of life you are going to do that. Why do we wait 24 hours?
Let the system start up.
The system's starting up like a computer? Sort of. You don't want to have any more mixing of mom and baby blood in any of the cord. Okay, so we said we're going to talk about PKU and galactosemia, unless you want to hear the other ones. We talked about the top of what that actually looks like and what a baby might present like. It's looking like that. True lethargy, true vomiting, where it's not GERD-like symptoms, where they're not having pain, they're not having weight loss necessarily, but it's just kind of this random vomiting. So when we think about PKU, so this is when you have phenylalanine, your body has an enzyme that will take phenylalanine and it will make it into tyrosine. Well, what happens when you don't have that enzyme? You don't have tyrosine and you have a bunch of phenylalanine. Right? What's the problem with phenylalanine? It's toxic. To what organ? The brain, right? So if you have a toxic chemical to the brain that's going to build up, that's not going to be very good for intellectual outcomes and your maximal potential. So how do we treat that then? Diet. What did we say? Diet. What do we mean? No, little phenylalanine. Okay, but what do we do for babies? What kind of formula? Yes, low phenylalanine formula. And that requires a script from the provider up in the top. Phenylalanine-free specific formula. So there's a lot of these inborn errors of metabolism where there are very specific prescription-only formulas that are very, very expensive, but that keep the babies alive. So it's going to be the difference. An adult, you could say, oh, you have PKU, let's have a low phenylalanine diet. But for a baby, they're going to require these very, very specific formulas that bypass the thing that they are missing. So phenylalanine is a great, or PKU is a great one, that we were able to bypass that one enzyme, give them the phenylalanine free until they can start solids that have the low phenylalanine diet. If you treat them early, so if you caught this with a newborn screen, right, and so you'll hear some people call the newborn screen the PKU because it used to just be one screen, one drop of blood, and it was just for phenylalanine, or for PKU. If we can catch that early, normal intelligence, normal kids, they go on to have normal lives, they can have relatively normal pregnancies, and all is well. If we miss this, that's where the intelligence and some of the profound intellectual disabilities come to play. So when they get pregnant, problem is, if a now adult has PKU and they get pregnant, the baby still needs some phenylalanine to develop. So they have to eat some phenylalanine while they are pregnant. So that you work very closely with a dietitian to make sure they get some phenylalanine, but not so much that it's toxic to mom. That make sense? What about galactosemia? What did I tell you about galactosemia block 1? Does anyone remember even hearing that word? What did you learn about it from block 1? What kind of special formula do they need? Galactose free, which is another way to say soy formula, exactly. So this would be the one time so you have a true contraindication to breastfeeding. So if you think about that, lactose is going to be made of glucose plus galactose. So anything that has any lactose in it, not going to work for that baby. So they are the only indication, the only true indication for a soy formula is galactosemia. The only true indication for this baby can't breastfeed at all, galactosemia. When they are fed lactose, so they cannot break this down, and you end up with all kinds of liver failure ultimately. So you end up where they cannot process their bilirubin, so you end up with all those hyperbiliary problems, and then you end up with their coagulation factors being an issue. So they come in very, very sick. It affects their kidneys as well. They come around back into the ER about within the first week, septic and trying to die. The way that I have seen this on board questions is talking about E. coli sepsis. So if they come in with E. coli sepsis, severe within that first week of life, so that an early onset neonatal sepsis, way back in block 1, if it is specifically E. coli in that first week, severe sepsis, one of the first things you have to rule out is galactosemia, the way that it uptakes with that. And avoiding galactose, so a lifetime of that. That is it. I need you to know those two, nothing else. For adrenal insufficiency, so we said adrenal, so when you have primary adrenal insufficiency, what's going on? The gland. So secondary, where's the problem? Brain. So in secondary adrenal insufficiency, what is your ACTH?
Low.
Low. What is your cortisol? Low. When you have primary, what is your ACTH? High. And your cortisol? Low. Okay. Which one are you tan in? Primary or secondary? Primary. Why?
Oh, it's like
What makes you tan?
the monocytes.
Your melanocytes. What stimulates your melanocytes? ACTH. So is that primary or secondary? Primary. Correct. So when your primary, when the gland itself is poopy, and it sends all that ACTH out, and your adrenal gland is like, I'm not listening, then the melanocytes are like, okay, I'll get tan. Yeah. So primary, so when you see tan, the way I've always seen this on your pants is they will say, the child it's winter, they live in Alaska, the whole family is very light-skinned, and this one child is very tan. And so you're like, they're trying to tell me something is weird there. So they'll always put tan is the way I've seen it in every single question. And they're really looking for, do you know what hormone is going to be high and low? So that's really the big thing. Those secondary ones, something up here isn't right, is not normal. One of the most common types is a craniopharyngioma. Where is that tumor? Craniopharyngioma. In the brain. Where in the brain?
Pituitary.
Where's craniopharyngioma? Colonel Peter teach you this one? It's on the pituitary. So craniopharyngioma is an embedded tumor inside the pituitary. So it's very hard. It's not like an adenoma or a prolactinoma where they can just shrink outside the pituitary. It's embedded in that pituitary. So it's a much harder one to deal with when they have that. If you are ordering imaging, you're going to get to phase 2 very soon in a couple weeks, and they say, I need you to order imaging for the pituitary. What kind of imaging do you need?
MRI.
An MRI? What kind of MRI?
Pituitary.
A pituitary MRI. What is that specifically called? Where is it located? In the cella. So in the cella turcica. So you order a cella series MRI. So for phase 2, when you get there and you're like, I need to look at the pituitary, you need a cella series MRI. Okay, back to the adrenal gland. So let's say we are back in this primary. So primary, your pituitary is trying so hard, sending out so much ACTH. You are tan, and your adrenal insufficiency is doing not much. So this could have happened because you had a hemorrhage. There's an infarct into your adrenal gland. Certain medications can do it, and a lot of these ones we're really not using in pediatrics, so this has never been a reason that I have seen. You can see some infections do this, some infiltrative diseases, so a lot of autoimmune. If you're having deposits of amyloidosis or sarcoidosis in there, that can do it. Most of the time in kids, it's truly going to be that the gland itself is not working. Primary adrenal insufficiency, where it is not making glucocorticoids and mineralocorticoids. Now, do you remember from Colonel Peter, oh, it says it on there, the adrenal cortex, right? So yesterday we talked about the adrenal medulla. So what's coming out of the adrenal medulla? Catecholamines. So which tumor are you testing those catecholamines for? Theo, and the one we talked about yesterday. Nephroblastoma, correct, right? Because it's the adrenal medulla. Your adrenal cortex on the outside deals with 3 things: salt, sugar, sex. Salt, meaning your mineralocorticoids, in that order. Those keep you alive. Sugar, cortisol. Sex, androgens. Salt, sugar, sex is what your adrenal cortex is in charge of, in that order to keep you alive. So when you have disease and autoimmune destruction of that, the ones that are going to keep you alive, you have to have mineralocorticoids and glucocorticoids. Those ones will keep you alive. So if you don't have those, it makes sense that you're going to have the hyperpigmentation. That's from the ACTH. Then the salt craving, because you're missing which one? The mineralocorticoids, correct. You don't have your aldosterone saying, come on back in. Hypoglycemia, because you're missing which one? Your cortisol, correct. And then you end up in shock because you're missing 2 of those. Your cortisol, how do you test that? Do you test it at what time of day? Morning. Your morning cortisol, so your AM cortisol. And that is going to be, again, low or high? Low. Low, correct. You can also see the hyperkalemia, hyponatremia, because again, you don't have those mineralocorticoids. And you are going to have to treat with a couple of medications. The closest one physiologically for kids is going to be hydrocortisone. So hydrocortisone is your go-to. What's the half-life of hydrocortisone taken orally? 8 to 12 hours. So how many times a day are you probably going to have to dose this? 2 to 3 times a day, depending on the kid. Typically is how you're going to have to do that. Your stress dosing is going to be 3 times that typically. So what types of things would you stress dose for? When they're sick, what kind of sick? Like I just have a cough? Fever. What else? Trauma. Potentially severe dehydration with nausea, vomiting. And then surgical intervention. So they're going to go in for surgery. You know their body's going to be stressed. They cannot respond accordingly. That would be another time that you would do that. And then your mineralocorticoids are going to take over that salt layer of your adrenal cortex. Got both of those. Okay, now you don't have this particular enzyme. So now the rest of everything is working, but you're missing your 21-OH. Okay, so now everything is getting shunted into what pathway? Salt, sugar, or sex?
Sugar?
Everything's getting diverted down into the androgen pathway, into sex. Okay? So you're like, shoot, I can't get to those other pathways, but I can get down this one particular pathway. So everything's going to convert to those androgens. So if a little girl is born with CAH, what does she look like? You do that first exam. What does she look like on exam? Huh? Yeah, so she looks virilized, right? So pleuromegaly, it can almost look like a micropenis. What does a little boy look like on exam? Your first neonatal exam? Totally normal, right? Totally normal, because he's supposed to have those androgens, right? Who comes back sicker then? Girls or boys? Boys, why? Because you didn't catch them, right? So they didn't get caught. You catch the girls, because you do a newborn exam, you're like, something's not normal, we need to do a workup, we need to figure this out. The boys just go home, because you're like, totally normal. And then they come back salt wasting, because they don't have those mineralocorticoids, they come back septic. That's typically what happens for CAH. So while you can pick up the girls easier, and they might have a more difficult time cosmetically, the boys more often die because you don't catch them in time. Endocrinology will help with that. And then good old Cushing's. So what has happened with Cushing's? What do we have too much of? Not, well, yes, you can have too much of that. You have too much cortisol. Yep, so what happens on here? You see that buffalo hump, you see striae, you see obesity, acne, all of the things with Cushing's. I have to say, I haven't seen Cushing's in a child unless it is iatrogenic, meaning they had cancer, they had some other rheumatologic issue where we were giving them exogenous steroids. So I haven't seen this in a lot of kids. Typically the pituitary microadenomas happen when they're a little bit older. So you guys will probably see that more than you will in a kid. But you will see a Cushing's-like syndrome that will often happen secondary to us giving them steroids for something. Another reason to not keep giving children steroids. Your diagnostic testing, so again, you can do your 24-hour cortisol excretion. Has anyone ever had to do this test or order this test or been around for this test? Okay, so when you tell a patient you have to do a 24-hour urine cortisol excretion, think about what you're asking them to do, right? They're going to go to the lab and they're going to get a gallon, it looks like a gallon of milk with no milk in it. And they're like, here you go, pee in this for 24 hours and keep it in your refrigerator, bring it back tomorrow. Okay, how many patients are going to be, especially kids, are going to do that real well, right? So when you're thinking about what you're asking the patient to do, this is one of those ones where you're like, okay, do I really need this test? If you really do, absolutely order it and let your patient know. If you don't, something to think about. And then again, depending on what it is, ultimately, endo will say, is this exogenous, endogenous? What do we need to do? Is this surgical? Is this something that we need to remove? How can we get rid of the excess of the glucocorticoids? Not as much, again, that we're seeing in kids, and endo will handle that. So, the big takeaways, I need you to understand DKA for this one. I need you to understand those just couple of your inborn errors of metabolism. And if you can remember some of those ways that it differs in kids, linear growth, with the way thyroid presents, those type of things that are slightly different for kids, those are those big endo topics. Yesterday, you guys had a little bit of life back in you. What happened overnight? It was Tuesday. The life was gone.
We knew we were doing that chemo.
Okay, surgery. Well done. You guys all passed surgery. That's awesome. Congratulations. Love that for you. Truly, there was a time here where people weren't passing surgery for a while. With old instructors, so we're doing great. Everyone's doing awesome. So when we're talking about surgery, really what I could probably call this lecture, if you're looking at what it is and what the pants wants you to know, is Pediatric GI 2.0. Because most of these things are going to be GI-related surgical issues. Now, is that all that kids are going to have? No. Is that really what the pants wants you to focus on? Yes. So that is what we are going to talk about for this. So in general, okay, back up a little bit. So this, just in general, this is from the syllabus. That's helpful. You guys like these ones? Yes. Noted. Got it. Okay. So what is polyhydramnios? There's a lot of what? There's a lot of fluid? Yeah, amniotic fluid. Too much? Yes. What's the opposite of too much? Too little. What's that called? Oligohydramnios. Correct. So oligo, too little. Don't get these confused. Poly, too much. How does the amniotic fluid move in a baby? Osmosis. So what happens, what do they do with it in their mouth? They swallow it. It gets absorbed in the stomach. It goes through, and then what do they do with it? It goes out where? They pee it out, and then they swallow it. And then they absorb it, and then they pee it out, and then they swallow it, and they absorb it, right? So if you have way too much fluid, something's gone on with that process. Okay? Somewhere in the gut, we're not absorbing, it can't get through. Something is wrong in the GI tract when you have polyhydramnios. Most of the time, it's a surgical cause. Not all the time. Could mean something's up with the kidneys. Could mean something's up with mom. But when I, as a pediatrician, see that there was maternal polyhydramnios in utero, I think to myself, what's going on with that kid's GI tract? Because I expect them to swallow it, digest it, pee it out. Swallow, digest, pee out. I expect that system. So when it doesn't happen, I think to myself, is there something surgical? So polyhydramnios, one of the things we see. The other thing that I see is delayed meconium passage. So when are you supposed to have that first poop?
First 48 hours.
The first, how long? How many? First day. So the first 24 hours. Yep. So when you're delayed and you're like, why aren't you pooping? And again, what's meconium look like? Black tarry stool. So when you don't have that, then you're thinking, I've got two options. There are two things that are going to cause delayed meconium. What are those two things?
Biliary tree.
No? We're going to talk about all of these, but you should think about two things. What if I told you, in the rest of it, that they, later on in life, have greasy stools? Steatorrhea. So steatorrhea, delayed meconium passage, what do they have? No, not celiac. Their what chloride is positive? Cystic fibrosis, yes. Right? So delayed meconium goes with cystic fibrosis as your number one thing. And your number two thing, I don't know if you guys talked about it in GI or anywhere. You guys talked about Hirschsprung's yet? Hirschsprung's. So the two things that you need to think about on the very tip top of your head, because they should be moving that and excreting it. So if they're not, cystic fibrosis or Hirschsprung's. Okay? So polyhydramnios, delayed meconium, those things already make me think this is going to be something surgical. If there's abnormal distension, that's when I think, where's the obstruction? Why can't things move through? This should be moving through very easily in a kid. If you have children, babies poop like how many times a day? Like a lot, right? You stop counting after like 4, 5, 6, 7, you just stop counting, right? So if they are continuing, if they're not doing that, then you're thinking, why is this not happening normal? And then vomiting. So the biggest thing, and part of your history taking for pediatrics, and really for anybody, is are you vomiting bilious emesis or not? because that's going to tell you where the pathology is. Is it upper GI, or are you past that ligament of Treitz and you are having lower Treitz? I never say that right. And that is going to help you with your location. So bilious or non-bilious, bloody, non-bloody. You'll see it often abbreviated NB, NB, non-bilious, non-bloody emesis. Thinking about surgery and children. This is scary. Most kids don't go in for surgery. So parents people in general are scared for surgery for themselves, times 10 for their children going into surgery. So very clear communication, why this is a necessary thing, why this is the only option or the best option, what's going to happen, how long do you expect them to be recovering, what it's going to accomplish, what the scars are going to look like. Those are the questions that the parents really want answers to, that sometimes, plus or minus, the surgeons aren't as delicate with. So sometimes they will come back to the PCM and ask you the same exact questions because they need it said in some human language. Love our surgeons so much, but they speak surgeon sometimes. Totally fine. That's where we're going. So, just some of those background considerations, and then we're going to start from the tippity top and work our way down into various types of pathology. So, esophagus and stomach. When we talk about esophageal atresia and TE, or tracheoesophageal fistulas. Did Commander Braun talk about these at all, or did you guys know these in GI? Okay. Because I'm a nerd and I have to go back to this, thinking about embryology, and as a reminder, I'm never going to test you on embryology, I just think it helps you understand it. If it doesn't for you, ignore me for the next 30 seconds. Your trachea and your esophagus, as that body kind of becomes 2D and wraps around, between weeks 4 and 6, there's the two pouching that comes down, and they collectively will make the esophagus and the trachea around the same time. So they should form in conjunction with each other. Okay? Because that happens, sometimes things don't form quite right, and they end up with aberrant connections, places where they shouldn't be. So you can have fistulas, you can have blind pouches, you can have all kinds of situations. Those are the situations we're going to talk about. So the most common type is going to be in that top left side of that, where you have esophageal atresia with a distal fistula. Okay? So at that top, that's just that blind pouch. So what's going to happen when you try to feed this baby milk or breastfeed? It's going to come right back up. Okay? So then you say, that's weird. Let me try to put an OG or an NG tube in. What happens? It just goes down and it comes right back out. Right? So if you put an NG or OG tube in and it comes right, you put it down their mouth and it comes out their nose, or vice versa, or it just kind of coils up on the bottom and nothing happens, that's the other thing. The other thing that you will see with this one is a ton of secretions. They can't swallow that, so a bunch of bubbles and secretions are coming up immediately after birth. So you're like, I just used the bulk suction, I got all of that out, and now there's more. This is weird. Okay? The problem then with that distal fistula is what's coming up from the stomach. All kinds of acid. Where's it going? Into the lungs. Yep, so two different problems there. Most common type. What happens with that middle type? What happens when you put that NG or OG tube in? Same thing. Yep. Now we just don't have a connection to the lungs. So we just are not there. Let's skip that one on the H type for a second. Let's go down to the bottom left. What happens with this one? They try to feed them. It goes straight into the lungs. So what does the baby then look like? Respiratory distress, choking, gagging, can't breathe, turning hypoxic immediately. If that happens and you try to feed them more than once or twice, stop feeding them, right? Because you're basically just pouring formula or breast milk down into their lungs. So, not going to work. Same thing for that, the proximal and distal, no bueno. Now the H type, what happens with this one when you try to feed? A little bit, but maybe not much. So most of everything goes down exactly normal. What happens if you put an NG or OG tube? It goes down just fine. What happens with the lungs? Maybe a little bit, maybe nothing. And so the H type is the type that gets missed. The H type is the type that they continue to go along, they continue to grow and develop, they get all the nutrients, they do well, but why are they always in your clinic? Pneumonias, respiratory issues, chronic coughs, chronic respiratory things that you can't figure out a good reason why, right? That's when you start thinking, do they have an H type of a TE fistula? Right? The other ones we caught right away, immediately after birth. This H type, that can get missed, and it comes out as that aspiration and recurrent respiratory illnesses. Slides in the wrong place. We already talked about polyhydramnios. You guys got that. So TE fistula, they get all of that excessive drooling. Already talked about that. Bubbling. Other things that you might see, way back in block 1, we said they might have a single umbilical artery. How many umbilical arteries are they supposed to have? 2. Yep, so it might have one. And it also goes with Bacterel. Now, I really think that Wager learned from Mr. Bacterel and really wanted to try to force fit an acronym. So Wager is the worst one, and Bacterel is the second worst one of all of the types of acronyms that he's really tried to make. Again, you're going to delay that and that risk of aspiration in mind. So when you see Bacterel, you're not as bad as Wager, pretty bad. So Bacterel is when you see this constellation of symptoms that you don't see with one underlying genetic cause. So you can't be like, this gene on chromosome number 15 is the reason, but you see this constellation of symptoms that go together. So some sort of vertebral anomaly. They could be having butterfly vertebra. They could be missing a spinous process. They could have any type of different vertebral anatomy. So one of the V's. Anal atresia. Do not have an exit passageway. So we talked about that in block 1. Nothing can come out. Didn't fully form there. Cardiac anomalies. So something is switched there. That could be any valve. That could be any of our congenital cardiac anomalies. Remember, what was our hand? What did we say? What was the thumb? Truncus. Arteriosus. What was the fingers? Transposition of the great vessels. What's the third? What's in the heart that has tri as the part of it? Tricuspid atresia. Tricuspid atresia. Tetralogy fluid. We got one. Yay! This one. My favorite. Yes. Total anomalous pulmonary venous return. TAPVR. Remember the pulmonary veins? Yeah. You go somewhere. Sad little heart. Hypoplastic left heart. Yep. And then
Epstein's.
wow, we got Epstein's anomaly. I love that. That makes me happy. What causes that Epstein's anomaly? Epstein's anomaly, atrialization, that right atrium. What maternal medication caused that? Lithium. Correct. Okay, so any of those cardiac anomalies, that's where we were. The TEF part is the tracheoesophageal fistula, a renal anomaly, and a limb abnormality. So the patient that I had that came to me had Bacterel, and his presentation was that he had a butterfly vertebrae. He had an anal imperforate anus with a fistula. He had dextrocardia. So he was that patient I talked about earlier that I listened and I was like, something doesn't sound right. Well, the heart's on the other side, on the right side. Had a TE fistula, had a horseshoe kidney, and then had syndactyly on one of his hands. Okay, but it could look a million different ways. So that was just the presentation. So when you start seeing multiple organ systems put together, think, is this one of those terrible acronyms? Is this Wager? Is this Bacterel? Change the look for it. So that H type could be one of the things. We already said, and you guys nailed it, you can't get that catheter down. So when I say orogastric, I could also say nasogastric in a neonate. So OG and NG, you can use interchangeably for neonates. Your chest x-ray, when we'll look at this, you're gonna see it in that little blind pouch, because it doesn't go anywhere. And anytime you're gonna do advanced studies with this, you need to use something water soluble. You use something non-water soluble, and there's a fistula. Where does that non-water soluble contrast go? Right into the lungs, correct. So that left side is that picture where you have passed a catheter and it goes right down into the blind pouch of that esophagus, and it can go no further because there is nowhere else that it can go. So that's what you're looking at. I think you can just see it better on the left than on there. And then this would be that gastrographin swallow study. So you're looking at the far right hand side, you put the contrast down into the esophagus. You see that it crosses right where that little black arrow is, crosses right over, and you see the contrast into the lungs. So you should see no contrast in the lungs. That would show you that there would be no fistula. So if you have any kind of contrast in the lungs, you have some sort of fistula. So this is a good example of that H-type fistula. What do we want to do with the H-type fistula then? We're going to cut it, right? We want to clip it. We want to ligate it. We want to do something. What happens if our two parts of the esophagus didn't join? You want to join them. What's another word for that? Reapproximate. Yep. Or anastomose, correct. Now, is that surgical anastomosis going to grow with the child? No. Darn it. Shoot. So that's one of the surgical considerations. How much? How far apart are those pouches? How old is the child? Let's say it's pretty far apart. We're like, that's not going to grow with the child, and we don't want to go back and do this over and over and over. How are we going to feed this kid then? A tube. Where are we going to put that tube? We're going to put it right into the stomach. So you're going to have a G tube. Okay. So you guys got it exactly. You can ligate that fistula and reapproximate it. It's not going to grow. So sometimes you end up needing a G tube for that kid until they get old enough. But then that becomes a problem too, because then they don't get some of that oral stimulation, they don't get some of that process of suck, swallow, breathe as they get older. So that is one of the surgical considerations. How are we going to fix this for this kid, and what is the long-term outcome? Don't know why the baby has power stance, but the baby does have power stance, and it's just the H type, none after the H type. You can just take this slide out. It doesn't really actually add anything. I should do something. For your complications, that makes sense. If we have created something and it is not growing with the child, that maybe you don't have great motility and that peristaltic motility, you can have reflux associated with this depending on how close it is to that lower esophageal sphincter. You could end up stricturing down and it stenosis down. You could see that. You could see leakage. Sometimes it will refistulize. That's frustrating when you're like, I just took care of you, now it refistulizes. And then you can have some of those respiratory complications after you surgically manipulated this area. So all things to consider surgically of post-op complications for these kids. Okay, pyloric stenosis, we're traveling on down. So statistically, 1 in 750 a year. So if you took all of the IPAP students in the senior class for a year, so 1, 2, and 3, and their siblings, statistically, we should have somebody with pyloric stenosis in class. I don't know, does anyone or their sibling have pyloric stenosis? Darn it, this is 3 in a row. I've been trying to see if this is, so the first 3 classes had somebody had pyloric stenosis. So I guess over 2 years that does even out, but I was just wondering if you would help my students. What do you know about pyloric stenosis? Palpable olive. Palpable olive. What is that palpable olive? What is the palpable olive? What's the pylorus?
Sphincter that reaches the water.
The distal end of the stomach, yeah. So when that hypertrophies, that becomes that palpable olive. So it is the pylorus itself that is hypertrophied. That pyloric muscle getting hypertrophied, and when it's so big and it closes off that exit outlet, now you have an obstructive process. So food can get into the stomach, it can't get out of the stomach. That should make sense then. Oftentimes firstborn children, oftentimes males. That is the classic presentation that I have seen on every single test question in the history of the world. 6-week-old male, 6-week-old firstborn male comes into the hospital with feeding difficulties. That's the first sentence of every question on this every single time. Number one, before the first 3 weeks. So this is what the classic thing that they will come in with. They come in at that 2 to 6 week mark. Every question again I've seen is always the 6 week mark. You can put a 4-week-old, that's totally fine too. They eat, they are satisfied for a few minutes, and then they end up with projectile vomiting. So when I, or you, or lay people, so not I or you, we're providers now. When lay people, your patients come in and say, my baby had projectile vomiting, what are they meaning most of the time? Gas bubbles, that they had vomiting everywhere around them, the car seat, the diaper, up the back, everywhere. It's just everywhere, right? As providers, when we're talking about projectile vomiting, what do I mean?
Across the room.
Across the room. So this baby is gonna like hit him. Right? 6 to 12 feet. Like it is going across the room because the pylorus is so strong that when it contracts, it truly shoots projectile vomit across the room. Right? So it looks like you're having an exorcism. Right? That's what this looks like. So when you're thinking projectile vomiting and parents are saying that, you're like a lot of vomit and it's a big problem in the car seat, or like exorcism. Right? Those should be kind of the way that you're distinguishing that. So projectile vomiting is true across the room. Then the baby looks ravenously hungry, right? The why? Because it didn't get past the pylorus. So it never got to the point where they can start to digest it. They come in then with failure to thrive because they're never getting those nutrients. Okay? So that would be another differential for your failure to thrive in that first month of life. You guys got it with the olive. You guys got it in that left upper quadrant that you're going to see this. And what I need you to know, starred, highlighted, underlined, is what your metabolic derangements are going to be. Okay? What is the acid that is in your stomach normally? Hydrochloric acid. Hydrochloric acid. So you're throwing all of that up. Makes sense? What's your chloride going to be? Low. Hypochloremic. Hypokalemic. And then you've thrown up all your acid. So this baby is alkalotic. Hypochloremic, hypokalemic, metabolic alkalosis. I have seen that on every board test I've ever taken. This particular one. I need you to know this for this upcoming test. This metabolic derangement. Okay. When you do the ultrasound of it, you see this gigantic pylorus. It's elongated, it's very thick, and then sometimes if you did a upper GI, you would see a string sign because there is a teeny tiny bit that continues to get through that gigantically hypertrophied portion of the stomach. So when you're looking at this, you get an x-ray, you get a KUB of this little baby, and you see the gigantic stomach, and then nothing after it. So no lower extremity gas bubbles, you got nothing else, you just have this gigantic stomach. That's it. I don't love this particular picture. This is looking at the pylorus. I like this one better. When you're looking at that pylorus, what I always see with this is a pickleball paddle. That's for whatever reason, that's all that I see. You see this gigantic dilated stomach, kind of like a butterfly or a hot dog bun, or a pickleball paddle. For whatever reason, that's just always what I see. It's the same picture, right? They'll give you something like this. It's a little bit harder to see. I can still see the pickleball handle. Or something like this, almost on every exam. Make sense where you're seeing that? Okay. So what do we got to do about it? We're going to do surgery. If you see this on ultrasound and you call the surgeon, what is the surgeon going to do? Say, hey, I got a pyloric stenosis.
Why are they not in the ER?
They're in the ER. You're the provider. Why? What are you going to do? You should do surgery on them, sir or ma'am. What are they going to do to you? What is the surgeon going to do? Yeah, they're going to hang up on you, and they're going to say, call back when you have fixed their metabolic derangement. Right? Nobody is going to take a patient to surgery, least of all a neonate who does not have appropriate electrolytes. Okay? Okay? So for the treatment for all of these, you're going to admit to a medicine unit first, because you have to get them hydrated and have to have normal electrolytes before a surgeon's going to touch them. Okay? That's kind of like when we talked about seizure management, and you're like, all of these are the same. You're going to give them the same seizure medications and prophylaxis and send them to neuro. It's going to be the same thing here. This is that string sign with the barium, so you see a big, giant, dilated stomach with a teeny, tiny little string going through. And that's going to be the big thing then, is you're going to have to, before they will take them to surgery, you have to replenish them with both fluid, because they are significantly dehydrated, glucose, because they are hypoglycemic, nothing has gone through, and you have to fix their chloride and their potassium. So the way we do that is we give them normal saline plus potassium chloride. You're like, that's convenient. Yep, they come like that. So you can get D5W plus 20 milliequivalents of KCl. You're like, that's going to fix it. That's got glucose, that's got fluid, that's got potassium, that's got chloride. Once their metabolic alkalosis has resolved and they have normal electrolytes, then they will absolutely take them to surgery. And the best example that I can give, has anyone been in this surgery? It's kind of interesting. It literally looks like they're like rotor-rootering through it. They literally just kind of rotor-rooter all the way through the pylorus to create an outflow tract. There you go. Open it up, rotor-rooting through. This is why I don't teach surgery. I'm like, you just kind of rotor-rooter it through, right? This is why I'm not a surgeon, clearly. Don't tell Commander Grant. That's what I was like, ski-wee. That's what's happening, okay? Pylorus stenosis. So, I need you guys for that one. How's it going to present? What age? What age? 6 weeks? Male? Female? Male? What's the metabolic derangements? Hypochloremic, hypokalemic, metabolic alkalosis, okay? Those ones, and that you're going to fix the electrolytes before surgery. Okay? Big takeaways for that. Congenital diaphragmatic hernia. Did you guys learn this in another class? You guys heard this? What do you know about this one? What's congenital mean? You're born with it. Lady Gaga, going this way. Diaphragmatic. What does that mean? Something to do with the diaphragm, okay? And hernia. So what's happening? What's herniating where? The intestines are herniating where? Into the chest. That's exactly what's happening. The intestines herniating into the chest. Again, back to embryology. 4 different things. Oh my gosh, why didn't somebody stop me? I can see your faces. Let's take a break. We're going to try to drag you emotionally just like 1 hour further today. Okay? Drag you. I'm going to do this. Okay, so congenital diaphragmatic hernia. You're born with something wrong with your diaphragm and your guts are herniating up into your chest. Okay. Again, I'm never going to ask you the embryology, so if you're like, there's a million slides in this block, okay, as long as you kind of know this, I'm not going to test you on this. It's just for some of that context and understanding. So embryologically, these 4 parts of the diaphragm all are forming together, and they come together to form one diaphragm collectively. Well, if that doesn't happen, specifically it's the pleural peritoneal membrane. It's typically on that posterior left side, as I point to my right, that's weird. Posterior left side, it doesn't form, so one of the 4 parts isn't forming, then all of a sudden you have this open space between your abdominal cavity and your chest cavity. Now which one forms first? The abdominal and all of your intestines, or your lungs? Really? Because what happens when babies come out? Do they have problems more with their intestines or their lungs? Lungs, so which one probably forms first? It's had more time to develop. You have abdomen, right? So your abdomen is going to form first. Embryologically, what ends up happening with that, did I have it out here? Yeah, we'll go back. So what happens for a baby, again, in all embryology, is the gut goes out of the belly button, goes out, makes the twists like it's supposed to, and then comes back in. Starts to form and continues to hang out there. Later on, at the very end, the lungs are developing and they're starting to form. Okay? Now, if that abdomen came back in and came back up that left side and is sitting in the chest all the time in the world to develop, now the lungs can't develop. There's no room for the lungs to develop. So it's not like the lungs are just like, hey, get out of our way. It just kind of sits up there shriveled. Gets no blood flow, and again, no flow, no growth. So this lung tissue truly doesn't form from that. So they end up with an either partial or a non-functional, often left side of that lung. So it's typically unilateral because it's typically that embryologic origin in that left posterior side. The other three parts kind of work together. So you end up with this big part of the intestines in that back posterior portion of the left side. Okay? So then what's that going to make the chest look like? Yes, the chest is going to come out. So they come out looking like baby Hercules, right? So they have this big giant chest and really nothing in the abdomen, right? So if you look at babies, you looked at them, right? They've got big old head, no neck, and then there's like another giant belly. That's kind of what the babies look like. This baby doesn't. This baby has big head, no neck, and then looks like Hercules and very slim and trim in their abdomen. Scaphoid chest. So when you see scaphoid chest coming down, that is what you are looking at. Scaphoid abdomen, sorry, and a big barrel chest is what you're seeing. Now, on exam, then you're looking at this kid and you're thinking, ah, in the chest cavity, instead of hearing breath sounds, you're hearing valve sounds in the chest because you have valve that forms just fine right up in the chest. And then they come out. They were getting oxygenated from mom's placenta and from the umbilical vessels, and now suddenly they're trying to breathe on their own. Oh, I only have one functional lung. So they come with a severe respiratory distress very shortly after birth. Okay? I've never seen a question on a board exam that didn't have the scaphoid abdomen, immediate respiratory distress, valve sounds up in the chest. They give you lots of clues that this is a congenital diaphragmatic hernia. On exam, that's exactly what you're seeing. You are seeing valve in that left side of the chest, right where it should not be. This is congenital diaphragmatic hernia. For this kiddo, I need to get their airway. So I need to take over the airway, sedate them, intubate them, and then I need to decompress. So it's going to be often the case where we are trying to take as much extra air out of the valve to decompress everything down so that it is manageable. So this kid, we are going to try to decompress that pressure on the chest that is there and on that left side of the heart. So in OG-NG decompression. And they need to get somewhere where they can have a surgeon manage this. So they will get intubated, IV fluid, decompressed, and off to that tertiary care center. So that's really what we're doing. The severity and how their long-term progression is going to be is how much actually herniated up in there, because how much lung grew. So how much pulmonary hypoplasia was there. Of the lung that did grow, that pulmonary hypertension, very similar to the congenital cardiac lecture, the pulmonary hypertension is often a rate limiting step because that's going to determine how much gets oxygenated up there, how much is herniated. So if you're like, if literally like the guts are just headed up there, you're like, we got some liver, we got some kidney, we got come on up into the chest. Worse prognosis than if you have a small amount of intestines that herniates. That should make logical sense.
Okay.
Yes.
Outside of the scope of this probably, but do they do anything if they notice this in an anatomy scan earlier? Like they do anything in utero? In utero?
That's a great question. I don't know the exact answer. I know that they will deliver at a tertiary center. So if you have this before, why in the world would you deliver at BAMC where you have no pediatric cardiothoracic surgeon? You're going to go deliver it down at Children's Hospital. So some like that, but as far as can they do early management for fetal surgery, I don't know, and I'll get back to you. Good question. Okay, so we just said the intestines left. Right, so they left while this baby was growing. Intestines come out of the umbilicus, and then they come back. But what happens if they don't come back quite correctly? So that's what the next set of pathologies is. They ended up doing their normal embryologic thing, but it didn't quite end up correct. Okay, so this umbilical hernia after the abdomen goes out or after the intestines go out and they come back, they didn't get the memo to tie everything off. So that step opening, where that hernia forms right at the umbilicus, still allows some of those contents to protrude. Now it's covered by the tissue, it's covered by some of the skin and some subcutaneous, so it's this hernia there, but it still is open, or it's still, the intestines are still coming out, and you can feel that. That oftentimes really freaks people out. So things that we are looking for, so that umbilical ring didn't close, so we see that, it's typically 1 centimeter in size. If you're guessing, or not even guessing, if you're measuring things in clinic, what are you using for about a centimeter? Yeah, finger breadth. So if you are a bigger dude with bigger hands, you might be using your pinky. If you're a smaller lady, you might use a finger breadth. So you're thinking, okay, how many fingers can I fit into this umbilical ring to measure this, right? So about 1 finger breadth is 1 centimeter. Anything more than 2, so if you can very comfortably get multiple fingers into this, probably not going to close on its own. You can get a finger, maybe 2, right into that umbilical ring. There's a high likelihood that over time, their kiddo's body will end up closing it itself. Makes sense that the lower birth weight and the more preterm you are, the less time your body had to get everything back up and do some of those finishing touches. So those are going to be an independent risk factor of that. And it will contain as much as kind of is herniating out there. So sometimes omentum or some of the small intestines. So these are the things that should be safe. Star, highlight, underline this one. See, like that's what I'm telling you, Steve. I'll be like, no, this slide. I need you to memorize it back to me. Just repeat the slide. Okay. So easily reducible. So what does that mean that you should be able to do in clinic?
Push it back in.
Push it back in. That means that the parents should be able to do that as well. I have had parents that are like, I'm not touching that thing. There's something alive in there. And you're like, no, it's just the intestines and peristalsis, and then you're explaining that, right? But they're like, So you and the parent needs to be able to reduce this easily. Most of the time, it's when they're about 6 months to about a year. That's a giant growth spurt. If you remember back from block 1, that's when you see capillary hemangiomas going crazy. That's when you see their growth taken off. It makes sense then why you would see why this hernia is getting bigger, because the baby's getting significantly bigger. The time when we say this has got to be surgical, we've watched it long enough. If it persists till they're 5 years old, you're like, 5 years? Yes, 5 years old. So you see it when they're 6 months, 1 centimeter, little finger. You watch them when they're 1, when they're 2, 3, 4. Now 5, unlikely to close, even if it was under that 2 centimeter mark. So 5 years old is when you send them off to surgery to do that. The other time is if there's any ever strangulation or it becomes incarcerated, it's very painful to them, or if it's increasing size after they've had it and they're 2 years old. So if they come in, you notice it, you can 1 finger breadth, it's been the same 6 months, that comes in and the same at 2, it's the same, and now they're 4 and it's gigantic, off to surgery even before they're 5. This is exactly what it looks like. This is why parents are like, I don't want to touch that. I had one parent who, and you don't need to do this, so you can actively leave this alone as long as parents know how to reduce it. But this parent was like, and they took a Band-Aid and would always like try to Band-Aid it down, right? And they're like, can I ace wrap it down? You're like, no, you don't need to, no, don't do that, right? So they settled by putting a Band-Aid over it. It doesn't work, so you don't have to do anything with this. This is one you would watch. So you're looking at that baby. What else can you tell about this baby?
It's normal.
Is that a scaphoid abdomen?
Yeah.
Nope. Does the baby look happy?
Yeah.
Yes. Was this a toxic, non-toxic kid?
Non-toxic.
Non-toxic kid, right? Baby doesn't care. The parents care more than the baby. Right? Good thing when you go to phase 2, you're on your pediatric rotation. That's one of those questions to ask parents. I use it often. Do you care or does the baby care? Right? Is the baby in pain or are you upset because, and you have to say it very delicately, but like, does it bother you that the baby vomits or does the baby vomit and just like sits there and giggles at you, right? Or is the baby in pain? Okay, so this clearly does not bother the baby. This bothers the parents, right? bothers us as clinicians. When does it bother us? When do we send them to surgery? How old?
Over 5.
5, or if it's getting bigger after they're 2. And how big? Typically will not close on its own? 1 to 2. So I kind of rule of 2. Good. Okay, so the intestines, they went out, they didn't come back. We got that. Umbilical hernia is one of them. Other version is when you have malrotation, and a midgut volvulus. So this one, it went out, and then it didn't come back in correctly at all. It's not that it didn't just finish going up, or that little umbilical ring didn't close. It did not come back in correctly. So this just kind of goes back in, and it was like, we'll just put it in there. Right? So it is just a malrotated intestine. It doesn't return. And when, because of that, now you have all of these lead points. When you have a lead point, what can happen? So if you think about this like a dancer, there's a lead point, you spin it, and it starts to become a volvulus. There starts to be this rotation. Okay? Anytime you have a lead point, you can intesticcept, you can spin around. In this case, because that lead point allows a spinning motion, you end up with a volvulus. Twists on itself, and now it's twisted so hard that what gets twisted in there? Arteries, veins, right? No flow equals no grow, and infarcting. So you end up with a volvulus that is going to infarct the downstream tissue and lead to necrosis of that tissue. If you have necrotic bowel tissue, very shortly you have what? Sepsis and an acute abdomen. Exactly. So this becomes your surgical abdomen very, very quickly. So you're on your left, your normal way that the intestines are supposed to come back and be oriented. On your right, when that doesn't happen, you now see this kind of, that's not correct. It's not the correct orientation. It's malrotated in there, and it can spin on itself. So, can you have a malrotation with no volvulus? Yes, it's most of them. Are they symptomatic or asymptomatic? Asymptomatic, right? So a lot of times we don't catch this malrotation until it's malrotation with volvulus, because that's how they come in and presenting, because it's now symptomatic. The presentation is now bilious emesis, as it's now past that ligament. So now you know anatomy-wise, we are way down into that. We are past the stomach, we are past the ligament, now we're having bilious emesis. So that is going to be, when you're studying this, you know which ones have bilious emesis, which one does not. It's going to tell you upper or lower. It's going to be super helpful. Again, a surgical abdomen, that acute abdomen, because they have that necrotic bowel tissue in there from that obstruction from the volvulus. You see this on x-ray, and it looks like you're like, what am I looking at? That's malrotation. Because this, you're like, I don't know where anything is. It looks, is it a uterus? Like, what's happening? What's going on? A why? Like, you can't, it's unrecognizable. So that's what malrotation is going to look like. And allows that. The other thing you might see would be a corkscrew effect. This would be a late sign where something has twisted over and over and over on itself. So never seen this in real life, but I have seen this multiple times on board prep questions where they have that corkscrew effect, and that's the volvulus that's involved. Treatment is going to be that same process. You got to get this kiddos ready for the surgeon. So the surgeon is going to say, I need them fluid resuscitated with an IV. I need that bowel as decompressed as possible, and then surgery will go in and do a laparotomy. They've got to take out any of the, they have to fix the volvulus, they have to take out any of the necrotic bowel, and then tack everything in its appropriate spot so it can't rotate again. So again, why I'm not a surgeon, we're not going to go into the surgical part. As a primary care PA, I need you to recognize it, know who to call, and know how you're going to prep them prior to the surgery. Intestinal atresia. What does atresia mean? Not connected or didn't form. Didn't form. So something of the intestines didn't form, didn't connect. what is that baby going to present like?
Not pooping?
Not pooping is one. What's going to happen before that? Vomiting. Yep. Is it going to be, so which is the soonest? The TE fistula, the pyloric stenosis, or the intestinal atresia? Which one vomits first? TE fistula, then pyloric stenosis, and then intestinal atresia. Okay, so these ones, they're going to vomit, but it's made it farther, so it's going to be later. Happens in several different locations. The thing to know about this one, to underline it, is that it goes with trisomy 21. This is one of those ones that kids with Down syndrome will often have. Can also be associated with malrotation, can be associated with cystic fibrosis, and an annular pancreas, things that we will see. The biggest one to know for that is Down syndrome. All the different places, so you might have the intestines that doesn't connect at all, you might have a missing spot, you might have it's close and the omentum is connected. So all shapes and sizes and different places that you can see this. Oftentimes this is where that polyhydramnios will come in. So they swallowed it, they can get it down into the stomach, and then it can't keep going. So they end up with this extra fluid because it is not following that normal path. They feed and they end up with bilious emesis. So for pyloric stenosis, was it bilious? No. What was that metabolic? What was your electrolytes? Hypochloremic, hypokalemic, metabolic alkalosis. Correct. So for this one, they're not throwing up stomach acid, so you're not seeing that. So you don't need to know that one because there's not anything that they're going to see there. But that failure to attempt or failure to be able to feed is going to result in bilious emesis. So now it's much farther down than into the stomach. Still going to have abdominal distension. That makes sense because things aren't passing. Sometimes more jaundice. And what we'll see here is the double bubble. So when we had pyloric stenosis, all we saw was the gigantic stomach. Well, now we're getting past that. So now we have one bubble as the stomach, and then we have part of the duodenum as your second bubble, and now nothing. Those are the two bubbles. Your stomach, first part of the duodenum, and nothing after that. So you don't see them. Your contrast study, and you will see both of those. You won't see that string sign, you'll see those two double bubbles. And the biggest thing to add to the lab, so if you see the double bubble, sure you can get the CBC and you're going to need a CMP to see how dehydrated, what their electrolytes are looking at. But why were we looking at the amylase lipase? Because we had the pancreas involved. So a lot of times you have that annular pancreas as part of this pathology. So that's going to be non-specific, but more likely positive when you have an intestinal atresia. There's going to be that annular pancreas. So an amylase and lipase is part of that workup. This should look familiar. IV fluid hydration, make sure their electrolytes are okay. Decompress the stomach, get them ready for the surgeon. And the one thing that we will do here, now that they are down into that lower part of the bowel where you are increasing risk for sepsis from some of your gut bacteria, you'll put these ones on broad spectrum antibiotics as well. In practice, you're going to do that for all of these. You're going to get these kids in pre-op antibiotics. But basic surgical management, basic pre-op management. Did you guys go over emphalocele and gastroschisis at all? You've heard of either one of these? Yes. Yes? Which class? New frontier. This is awesome. Okay. So we said everything goes out. Keep saying that. Something's going wrong with that. Well, what happens if it goes out and it doesn't come back in at all? Well, that's where these come into play. So they look very similar, but they are not. So gastroschisis, we'll start with that one. So gastroschisis, it comes from a kind of word that means to split open. And so you have some sort of abdominal wall defect. So everything went out. The abdominal wall is the problem, and so things aren't coming back in. It's supposed to come back through the umbilicus, which made sense for that umbilical ring that didn't close for your umbilical hernia. But this, the way you know that it's the wall defect, is that the umbilicus is not involved. So star, underline, highlight that. The umbilicus is not involved in gastroschisis. So you know that it didn't come back in the normal way because it's supposed to come back in the umbilicus. So if the umbilicus is like, I'm just here, I'm still fine, you know that it didn't come back in the normal way, and there's something wrong with that abdominal wall. Some other thing could be happening. Is it the blood supply to the wall? Was there missing an artery? Did something rupture? Don't know, but it's not the umbilicus, so it didn't come back that normal way. Okay? When the guts are now out, they're exposed to the amniotic fluid, right? They're not supposed to be. They're not supposed to be exposed to the amniotic fluid. The skin of a baby, of a preterm infant, is built to be bathed in amniotic fluid. The intestines, not meant for amniotic fluid. So it ends up building kind of a thin film on it, that when they come out, very irritated. So those guts are very, very, very irritated. You can also see intestinal atresia with this, not as common. Again, I want you to put intestinal atresia with Down syndrome. And you have to make sure that when we're correcting it, you cannot live with your intestines on the outside. So somehow we have to get what's on the outside on into the inside. It takes a long time because if you didn't make that abdominal cavity, there's nowhere to put it. It's not like, because that's what I always thought, right? At first, when I'm learning this, I'm like, well, if they have the abdominal cavity and it's on the outside, can we just kind of like stuff it like a sleeping bag and just kind of like stuff it back in? Like, well, no, because the abdominal cavity didn't grow. So there's nowhere to put it back into. That was the problem in the first place. So they get put on long-term nutrition via the IV, oral parental nutrition, while we figure out how to make this abdominal grow. This is how the baby is delivered. So this is to your point, to your question about the congenital diaphragmatic hernia and what we do in utero. This is one that we can see. So this is that anatomy scan at the bottom right over here, where you can see the baby and you see that the guts are on the outside. They should have returned by now, by the time you do the anatomy ultrasound. They are on the outside. So you know you've got a gastroschisis going on. This is how the baby is delivered. How do I know that the umbilicus is not involved? In this picture on the left. Picture on the left. How do I know the umbilicus is not involved? Because you can see it. It's right there. It's totally normal. Right? You see what I'm talking about? That's the umbilicus right there. Totally normal. Totally not involved at all. Right? It's normal. So I know it didn't go past that. The baby's guts are all on the outside. The umphalocele, very similar, except that everything went out through the umbilicus and then just didn't return. Okay? So the umbilicus is involved. And when you have that part, you know that it tried to do the normal thing and it got stopped for some reason. So it's more likely to have something else genetic going on with this because the normal process didn't function at all normal. So that's the way that oftentimes questions are worded for the PANCE. Which one is more associated with genetic or congenital anomalies? Gastroschisis or umphalocele? Like, it's got to be the umphalocele because it started that normal process with the umbilicus and it didn't finish correctly. So something more likely genetic is going on rather than an isolated wall defect. The thing with the umphalocele is that oftentimes they will come out and see a picture. That is what will happen. So it left and then didn't come back. So the umphalocele is still got a casing and a covering around it. Does that make sense? It left the umbilicus, didn't come back. Or we just totally did. We are totally did. We all did. Okay. So it is still covered. The umphalocele didn't return. It's still covered with peritoneum and the amniotic membranes. The syndromes that are associated with is oftentimes cardiac and Beckwith-Wiedemann. Wait, we talked about Beckwith-Wiedemann yesterday. It had some tumor associated with it. What was the tumor that was associated with Beckwith-Wiedemann? It has a renal origin. Nephroblastoma, that hemihypertrophy. They have one Popeye arm, one Popeye leg, hemihypertrophy is what you're seeing. Back with Wiedemann. Nephroblastoma, what's the other name for nephroblastoma? Wilms tumor, correct. Yep. What's that syndrome that it goes with? Worst acronym ever. Waitress, correct. Okay, so you have a omphalocele on one side, went out the umbilicus, normal way, did not come back, genetic. Gastroschisis, something with the abdominal wall, not involving the umbilicus. For both, decompress the bowel, start them on IV fluids, they get IV nutrition, and then you gotta cover it, right? You can't live with your intestines on the outside, so you have to cover it, keep them from getting infected, keep them from losing a bunch of fluid, heat, and water, and then they need to go to a tertiary care center. If it's small and they have an abdomen that can fit, you can get it all back in, that's totally fine. But a larger one needs a long time for that to grow. So what have we done? This was ingenious, I think. How do we make the abdomen grow faster? What do we do?
Go over there. Go over there.
We fill it with something, but not air. So we basically harnessed gravity to help us. So we said, what if we can suspend the intestines in the air and let gravity just weight it down and to force the abdomen to grow? And that's what we do. So we put the abdominal contents in something called a silo, and we let them slowly sink into the abdomen as we force it to grow. Looks like this.
Are these patients not already, like, they don't know this is already a thing? Like, aren't they already at those care centers?
Most of the time they are. So like this one we do advancing. So they do this advancing. So you're gonna do something where they have a higher level NICU. Yeah. And so this is what they do. This is a silo. So this bottom one over here is A is how they're born. So I know it's a gastroschisis. How? Yeah, I got that umbilicus right there. So it's a gastroschisis. I put it in the silo, both in there, and I just let it slowly get down into the abdomen until eventually, looks like that. And drop it into the abdomen over time. You guys are looking at me horrified right now. It's actually really, really neat. Let's see if there's that other picture of it. So baby comes out, and this is another version of an older silo that they kind of used to drop it in. Now this one, where we have this, we can also add liquid so that they can actually, we can keep the intestines moist. And then it closes up, and that's where their umbilicus is now. You guys look horrified right now. Are you horrified by this?
How long of a process are they stuck with
Great
that?
question. Of how long? It can take weeks to months.
So they're just stuck laying on
Yes,
their
the
back?
babies are laying on their backs most of the time, so they have a lot of time in the NICU where they have OT and PT. If you're ever like OT and PT in the NICU, yep, they come and they reposition them, they move their arms and their legs, and they do all kinds of stuff while they're sedated and we're growing their abdomens.
Sorry, they're growing the abdomen part. I guess I'm confused. Are we like pulling traction on their skin or anything?
No, it's the gravity. It's just hanging above them, and it slowly drops into the abdomen over time.
It's like the pinpoint force in that making it.
Mm-hmm. Yes, ma'am.
Yeah, we mentioned that they are sedated the whole time.
Some of the time, after a while, they are kept comfortable because this is uncomfortable, but after their airway is first good, they will end up just kind of waiting for their abdomen to grow. So they're not intubated the whole time, they're not sedated the entire time. As long as they are comfortable, we back off on the sedation. And what? Your faces right now are horrible. Welcome to peds is like interesting. If you all wanted to do peds, none of your faces do now. Okay, this is fantastic. So that's gastroschisis, the silo, how we manage it.
Can't imagine explaining.
This is what they're looking like. So they'll come out and they will end up, this is the first part of management. So they end up, this baby is intubated. Let's see, what do we got here? That's the silo. This baby has TPN running into the central line and then is intubated. So that's the beginning of how you would silo the intestines or gastroschisis. Your face looks horrified. Yeah. Yeah, it's a sterile, so it's every time you are changing the dressing, it's a sterile procedure. They're doing common changes. I'm gonna find some stuff for congenital diaphragmatic hernia and the silo. I think it's cool. You guys don't think it's cool. I am sensing this, getting this sense, right?
Why do you skip
Okay, what do you know about Meckles then? Let's go back into something that seems a little bit more comfortable. Twos, this is like the ultimate pediatric one, right? Two what? 2 centimeters of what? Oh. Okay, listen to 2 types of tissue. What are the 2 types of tissue? Gastric and pancreas. Okay, what do those 2 things have in common? They secrete things. What do they secrete?
Insulin and digestive enzymes.
Enzymes and what does the stomach secrete? Gastric tissue. Acid, right? Hydrochloric acid and enzymes, right? So if you're secreting these 2 types of tissue, is the alkaline large intestines made for that? No. So what's going to happen?
Irritation and
Irritation, and you got some issues there, right? How old is this child when they present typically? 2 years old. And what's this? What's it? 2 feet?
in the cecum.
Yep. Okay. So you guys got that. The remnant of the vitelline duct. We said that was partly that made it the bypass in utero, so that you could bypass part of the liver, go straight back to the intestines. It doesn't obstruct all the way, and you end up with those 2 different types of tissue, the gastric and the pancreatic. It's secreting, ulcerating, and now bleeding. You guys got that? Your rule of 2s. Gastric pancreatic, 2 years old, 2 feet from the cecum, and it's typically 2 inches long. So this is literally the perfect pediatric one. All the 2s. Yes, the 2s. Meckles was made for pediatrics. They will come in, and the biggest part about this is determining, is it painful or painless? So for a Meckles, this is not painful. This is always baffling to me how it's not painful. You're like, it's ulcerating through. Don't understand why it's not painful, but it is a painless GI bleed, and you're seeing that ectopic tissue. When you have this, the biggest part, it's almost like malrotation with volvulus. They kind of go together. This is now another portion that has this aberrant tissue, this aberrant way that it is functioning in the large intestine, that becomes that lead point also. So instead of volvulizing, I'm not sure that's a word. Instead of becoming a volvulus, volvulizing, can somebody look up if volvulizing is a word? I don't think it is. Instead of rotating, this one creates a lead point that allows that intussusception for the telescoping. So that kind of lead point. The Meckles scan. So you will see both of these written like this on test questions. You'll see a Meckles scan, you'll see a Titanium 99 scan, you'll see a Meckel, or both of those, you'll see them written both ways, so please know both of those. You can do in different types of laparoscopies or endoscopies, but typically you're going to most likely do a Meckles scan. What happens with a Meckles scan? Did you guys go over this in RADS? Way back in the day? Okay, so a Meckles scan is going to look like this. So you put the contrast in, it's going to pick up gastric tissue. So you should see it in the stomach. That's what you're seeing up top. Then you're seeing this little part where the blue arrow is where you're seeing a second type of the gastric tissue. Behind it, it's going to be secreted again and out by the kidneys, so you're seeing it down the ureters into the bladder as the collection point. But that little area where that blue is positive is where you're seeing there's a second area of pickup of that gastric tissue that you shouldn't see. That's what that Meckles scan is going to look at. Complications certainly make sense. If you're going to ulcerate, you're going to bleed. If you ulcerate, you can perf. If you ulcerate and then you have that lead point, you can now obstruct. So you end up again with a surgical and an acute abdomen from your Meckles. Surgery is going to want you to do what with them? How do you pre-op them? Decompress. Fluids. And checking your electrolytes. Okay? Getting them ready for the surgery every single time. How about some of these anorectal? We're almost at the bottom of these surgeries. So imperforate anus, we already talked about. Way back in block 1, there is no exit hole. So we have nothing that's going to be allowing them to have that normal anal opening. If there's no exit, should you feed this baby orally? No. It's going to be the biggest thing. We're like, well, it's got some time. Maybe it will all absorb. You're like, no. Right? Baby doesn't have exits. Don't put anything orally. You will hydrate them through their veins and allow them to urinate the excess out. That will obviously mean that you will see no meconium, or if you do, it's from a fistula. So that's why you literally, on that first exam, make sure that there is an anal opening, that there's not any fistula next to where the anal opening should be, from the vagina, down in the scrotum. You want to make sure that there is not there. The fistula can be anywhere from there. If there is that fistula, or if it is connected to the urinary bladder at all, you're going to want to also decompress that bladder for any urinary distension as well. I had a friend, a little mental break for a second. One of my friends from residency, she got Japan as her first station. So she's the pediatrician, sole pediatrician, goes out to Japan. They have a nursery out there. And NICU, goodness, thank goodness. And very first night on call, very first delivery, baby no known problems in utero. Baby comes out, she does her first exam, imperforate anus. Very first night in Japan, figuring out how do I transfer to a tertiary center for pediatric surgery for imperforate anus. Ultimately, it went back to the same concept. I need IV for hydration, for fluid, decompress the stomach, make sure the electrolytes are okay, figure out over time where do I send this baby. Same concepts that you guys have been using. The other one on the right is going to be what a fistula would look like. The other thing that we look at is anytime that you have an imperforate anus, the other thing that I worry about is, do you have a tethered spinal cord? So is something else abnormal with the lumbosacral anatomy? So if that is the case, part of the workup and what the primary care would be doing a MRI of that whole lumbosacral region to see what else is going on. Do I have a spina bifida? Do I have a tethered cord? Do I have something else that is not correct there? Oftentimes, this will be a colostomy where they will have to divert to have that exit hole while then they recreate an anus for this child and allow it time to heal before they can reanastomose. What do you know about Hirschsprung's? You know something about it today. Talked about Hirschsprung's a little earlier. What happens with meconium in Hirschsprung's? Delayed. What's the other thing when you have delayed meconium? Hirschsprung's and cystic fibrosis. Correct. Okay, so you have, what are you missing with Hirschsprung's? Nerves. What kind of nerves? Yeah, the colonic ganglion cells that allow for movement and peristalsis right at that rectoanal junction to be able to defecate. So if you don't have that and nothing can move through this teeny tiny passageway, what happens to the poop? It backs up, right? What happens to your intestines? They just continue to stretch and stretch and stretch. That's why this is also sometimes called a toxic megacolon, because you just end up with waste products that's continuing to expand over time. So this toxic megacolon is what you end up with. It's the most distal segment, so you're going to have more problems the farther up you are missing those cells. So the longer segment you're missing nerve cells, the harder or the bigger problem this is going to be. Anything right just proximal to that is going to be extremely dilated. That's where that toxic megacolon is. Again, they don't pass your meconium, so that should be a red flag. You see on any question stem, the nurse reports after 24 hours the baby has not passed meconium. You need to be looking for NCF or something with Hirschsprung's here. We'll often have a very distended abdomen, and And again, bilious emesis, because it is way down at the end, so you know it's some sort of distal pathology when you have bilious emesis. This would be the one time that we would indicate for a neonatal DRE. Notice, throughout 3 months together in here, I've never once said that we should do a DRE on a child. This would be your one indication to do a DRE, because it's going to be both diagnostic and therapeutic. So you're going to see if you, and I recommend, what finger would you do this with? Pinky fingers, right? So you don't need much for these little babies, but you have your finger, and when you bring it out, they will have an expulsion of stool. And you'll also see that they don't have any of the normal physiology of how things are supposed to look. So that toxic megacolon before the proximal segment. Again, barium enema will show that same thing. What they're always looking for is what's your definitive diagnosis. The surgeon will have to come and do a rectal biopsy. You will see that there are none of the ganglion cells. So that is what is missing. They're doing that. The manometry will show you the same. Cut it out, cut the segment out. So they will go up and they will continue to biopsy until they get to a part where there's ganglionic cells. So oftentimes this is multiple layers of biopsy, because they're not just trying to guess and be like, oh, we're going to cut this much out. They're going to try to cut out just what doesn't have those ganglionic cells. And multiple biopsies, they'll cut at that point and then try to re-anastomose. They can't re-anastomose right at that particular time frame. They will get a temporary colostomy and re-anastomose at a different time. Let's call it here, before you just move it.